Hi everybody, welcome to the webinar. I'm Dr. Jeff Donovan. I'm really happy that you could join me. We are really witnessing a wonderful phenomenon in the world now, and that is the second approval of a JAK inhibitor for patients with severe alopecia areata. And I'm really delighted to be able to speak to you today about this new medication, Ritlecitinib, and to review with you its efficacy, to review with you how it compares to Baricitinib, which was approved almost a year ago on June 13th, 2022. And here on June 23rd, 2023, we have the approval of Ritlecitinib. So really an exciting time, a time where we need to think carefully about what the data means, think carefully about what this means for the hair loss community. We will be witnessing many new JAK inhibitors in the years ahead, as well as new drugs. And I think it's important to reflect on these treatments and how the trials were designed, what we know so far. And I think it's incredibly important for us all to reflect on what we don't know. And while it's a time to be very excited for the promise that awaits, I think it's important to keep in mind a number of principles, and I'm delighted to be able to speak to you today. So I'm going to share my screen and we will get started. If you have any questions, please do enter them in the chat. There will be an opportunity, of course, to review questions at the end. So Ritlecitinib is a JAK inhibitor. It also inhibits other pathways in immune cells, but it is a JAK inhibitor. The company has decided to call this drug Litfulo. And Baricitinib is the other JAK inhibitor that has been approved last year. So what I'd like to review with you today is the benefits of this drug, Ritlecitinib, and the side effects and how it compares to Baricitinib, and to review some key principles. So it's been a year of tremendous excitement. June 13th, 2022 was really an exciting day because we have been waiting for the FDA approval of some kind of drug for alopecia areata for a long time. I think there's about 20 treatments for alopecia areata that exist in the world that are commonly used, ranging from topical steroids, steroid injections, minoxidil, diphencyprone, squaric acid, anthralin, cyclosporin, methotrexate, sulfasalazine, but none of them were FDA approved. And so that they were all off-label. That comes as a surprise to many people, that with the thousands and thousands of steroid injections into the scalp that get done, it's actually not an approved treatment, even though it's highly effective for patchy alopecia areata. So we were waiting for this FDA approval. And on June 23rd, 2023, we had the approval of Ritlecitinib, which has now been called Litfulo. This drug was approved for severe alopecia areata. Now, as many of you are aware, alopecia areata most commonly presents with a patch, a circular or an oval-shaped area of hair loss. This patient on the left side of the screen has an oval-shaped area of hair loss. Steroid injections, topical steroids, minoxidil would be the way to go for localized or smaller areas of alopecia areata. Severe alopecia areata refers to hair loss involving 50% or more of the scalp. Severe alopecia areata is very challenging to treat. Steroid injections don't work all that well. Topical steroids don't work all that well. Minoxidil doesn't work all that well. And so we have been using for decades potent immunosuppressants like methotrexate, like cyclosporin, like sulfasalazine, like azathioprine to try to calm down the immune system to stimulate hair growth. Those treatments aren't entirely effective in all patients, and there's considerable side effects. And over the last many years, it's come to be understood that there are specific pathways specifically this JAK pathway, the Janus kinase pathway, that seems to be very relevant to alopecia areata. And so these drugs that inhibit this pathway in immune cells, called JAK inhibitors, have risen to the top as a very effective treatment for severe alopecia areata. Baricitinib inhibits JAK1 and JAK2. Ritlecitinib, this new drug, inhibits JAK3 as well as TEC. And ritlecitinib actually has very little ability to inhibit JAK1 and JAK2, which are the other members of the JAK family. There's 4 members of the JAK family: JAK1, JAK2, JAK3, and TYK2. But ritlecitinib also inhibits this TEC. And TEC is a kinase family, which has 5 family members in it. And so ritlecitinib not only inhibits JAK3, but inhibits this other family. And the manufacturer of ritlecitinib, which is Pfizer, Eli Lilly is the manufacturer of baricitinib, often refers to ritlecitinib as a kinase inhibitor. Of course, it's a JAK kinase inhibitor, but it's a kinase inhibitor. It has other kinases and enzymes that it inhibits in immune cells, not only the JAK pathway. So let's take a look together at the studies of baricitinib. Then we'll look at the studies of ritlecitinib. The baricitinib clinical trials are known as the BRAVE AA trials, and the clinical trials of ritlecitinib are known as the Allegro trials. So we're going to look at these very important clinical trials, make sense of them, remove from the data what's really important for us all to be aware of. So let's begin with baricitinib. I'd like to mention 3 wonderful studies that have, 2 of them have been published and 1 of them has been presented at a recent conference. Dr. King and colleagues published the landmark study in the New England Journal of Medicine last March, summarizing the phase 3 trials of baricitinib. And earlier this year, Kwan and colleagues, the same group, published the 52-week data. Dr. King's study was the 36-week data. Dr. Kwan's study was 52 weeks. And at the recent AAD meeting, several investigators in the group, including Dr. Senna and Dr. King, shared the 2-year data, the 104-week data. So we've got lots of data pouring in with baricitinib. So let's take a look at it, and then we'll take a look at the ritlecitinib data. So the BRAVE AA1 and BRAVE AA2 data for baricitinib was shared in that New England Journal of Medicine article. And it was this data that the FDA said, this is reasonable to grant approval. And so they did so on June 13th, 2022. The BRAVE AA1 and BRAVE AA2 trials were 2 separate trials, but they were very similar. Patients received either baricitinib 4 milligrams or 2 milligrams or placebo. So it was a placebo-controlled trial. In the BRAVE AA1, there was about 650 patients or so that entered, but 598 completed the study. Over 500 started the BRAVE AA2, but 490 completed the trial. So about 90% completed the trial, which is pretty good. And what was the primary endpoint that the investigators were looking at in the BRAVE AA1 and AA2? Well, they started with patients with severe alopecia areata, 50% or more hair loss on the scalp. And a large proportion, as we'll see in a minute, had complete hair loss or almost complete hair loss. But what they wanted to determine was what proportion at a 36-week cutoff achieved a SALT score of 20 or less, which means 80% regrowth, which we'll look at in a minute. So they wanted to figure out how many patients, what proportion of patients achieve 80% hair regrowth. So what is a SALT score? The SALT score has nothing to do with SALT, but rather has to do with an acronym, Severity of Alopecia Tool, Severity of Alopecia Loss Tool. It's not difficult to understand. If you say that a patient has a SALT score of 100, it means they have 100% hair loss. If you say that a patient has a SALT score of 0, it means they have zero hair loss. So it's a severity of alopecia loss tool. And so a SALT 20 is 20% loss or 80% growth. And so in this particular study, the investigators wanted to figure out what proportion of patients at week 36 reach a SALT score of 20 or better. In other words, what percentage of patients achieve 80% coverage or 81% coverage, 82, 85, 90, 95, 100. 80% or better. So at week 36, what's the answer? 38%. 38.8% in Brave AA1, 35.9% in Brave AA2. So just over a third of patients achieve a SALT score of 20 or less, or 80% hair regrowth. That was a very, very important study. Patients that were involved in that 36-week trial were invited to continue, and these are called extension trials. The FDA is quite strict, and other regulatory agencies around the world are quite strict. The initial trials are important, but the regulatory bodies say that you must continue to study this drug. And you must continue to study the drug for several years after it is approved, if approval is indeed granted. And so these are extension trials. And so after the 36-week trial, the next landmark was to figure out how patients are doing by week 52, and then how are patients doing by year number 2, or week 104. So Kwan and colleagues published March 2023 the 52-week data. 52 weeks is 16 more weeks from the landmark 36-week data published in the New England Journal. So how much better do patients do with 4 more months of treatment? Not that much better. At week 36, about 38.8% of patients in Brave AA1 achieved 80% regrowth. At week 52, so 16 more weeks, it only rises up to 40.9. In Brave AA2, 35.9% of patients reach that landmark, as I mentioned. At week 52, it only rises to 36.8. So 16 more weeks of time going by doesn't increase the amount of people reaching this set criteria all that much. So what are the criteria? What are the side effects of baricitinib? Well, the side effects of baricitinib are somewhat similar to the side effects of JAK inhibitors that we have been thinking about and talking about for since 2015 in the alopecia world. Somewhat similar to tofacitinib, somewhat similar to ruxolitinib. Upper respiratory tract infections, headaches, nasopharyngitis, acne, 6% of patients, urinary tract infections in very small numbers, increase in muscle enzymes, which are generally of no consequence, increased COVID infection, and increased herpes zoster in very small proportions, about 0.5%, upwards of 1%. In the 36-week data that initially came out in the New England Journal, the authors mentioned there was a patient that had a lymphoma, a cancer. In the 52-week data, Kwan and colleagues mentioned that there were additional cancers at week 52, a patient with ductal carcinoma in situ, a type of breast cancer, and a squamous cell carcinoma as well. And as we'll see in a minute, at the recent American Academy of Dermatology meeting, Dr. King and colleagues shared that so far we have about 5 cancers. A leukemia, some breast cancer, a melanoma, and a melanoma in situ. And we'll take a look at that. But at the 52-week time point, so 1 year of data, there were no blood clots. And blood clots have been really important to follow because other studies in the rheumatoid arthritis literature and other patient populations have reported blood clots. There are no opportunistic infections, no tuberculosis, no gastrointestinal perforations, which had been a worry in some of the prior tofacitinib data. There were no deaths. And so Dr. King and colleagues presented data at the AAD. Dr. Senna presented data, Dr. King presented data. And this is the 104-week data. 104 weeks is 2 years. This is really, really important data. Patients with alopecia areata should, for the vast majority of patients, remain on these medications for life to maintain hair. And so it is important what happens side effect-wise at week 36. But if someone is going to remain on the medication for 26 years or 36 years or 45 years, we need long-term data. And so 104-week data is very, very important. And so Dr. King presented data at the American Academy of Dermatology, one case of a cardiac event, major adverse cardiac event, or MACE, one DVT, or pulmonary embolism, so a blood clot, and then malignancies other than the non-melanoma skin cancers, the B-cell lymphoma, which we saw in the 36-week data, breast cancer, CLL, chronic lymphocytic leukemia, a melanoma, type of a skin cancer, and a melanoma in situ, an early stage. So this is really important, and these studies are challenging to sort out what is related to the medication and what happens unrelated to the medication. Human beings develop blood clots. Human beings develop cancer. Human beings develop side effects. Human beings develop medical phenomenon just by virtue of time going by. And so it's challenging sometimes to figure out, is this related to the drug they received, or was this side effect likely to have occurred anyways? And we'll talk a little more about that in a minute, but it can be very challenging in these clinical trials when you have a participant who develops a cancer, a blood clot, a cardiac event, to sort out, is it because they received the drug and they were participating in the trial and they got the drug, or even if they weren't participating in the trial, would they have had this side effect? It can be challenging, and the best answer is certainly time. And now that we have 2 drugs that are FDA approved, it would be very important to continue our long-term evaluation of these drugs, because if we start seeing side effects that are happening more commonly than we would expect, or if we see side effects that are happening consistently in long-term users of Baricitinib for alopecia areata, long-term users of Ritlecitinib for alopecia areata, long-term users of tofacitinib, upadacitinib, then we can start to say that maybe these side effects truly are related. So those are the BRAVE AAA trials. Really important trials. The study design of those trials being quite rigorous. Of course, they're placebo-controlled trials, but well-monitored, well-documented clinical trials. And I think the New England Journal paper by King and colleagues in March 2022 really is a very important paper to understand how a good clinical trial needs to be done for patients with alopecia areata. So now we have Ritlecitinib, Litfulo, which was approved June 23rd, 2023, 5 days ago. And it was the Allegro trials that convinced the FDA that we should grant approval. It was the BRAVE AAA trials that convinced the FDA to grant approval to Baricitinib. So the Allegro trial had 718 patients. They were randomized to various doses, not just 2 doses like the BRAVE AA trials where patients had 4 milligrams or 2 milligrams. The Ritlecitinib trial was a very complex clinical trial, and there were 7 study groups that we'll review together. 118 sites or different offices that were participating, 18 countries. 55% of patients in the Ritlecitinib study were female. Different racial backgrounds were included in the study. 61% were white, 33% Asian, 4% are black. And that's really important. We need clinical trials to be varied in the patient populations. That's really important. But it's also very important when we come to interpret data. And so if I'm seeing a patient in clinic, what I need to do is think back. What patient groups were in the clinical studies? What were their ages? What were their racial backgrounds? What were their medical conditions? And so it's very important. This study had 4% of patients that were black. So we do need to keep that in mind always, the background of patients that were included in these studies. But what was so important about the Ritlecitinib study was it included adolescents. It included individuals from 12 to 17. Now, it didn't include a lot of individuals from 12 to 17. That's important to remember as well. But it did include individuals, about 15% of those patients, of those 700 patients. The mean age was 32. And so that's important. And so if you're seeing a 71-year-old patient with severe alopecia areata in clinic, you will, first of all, want to ask yourself, what drugs are approved for a 71-year-old? And as I look back on the clinical trial data to tell the patient in front of me how likely it is to help, I have to remember that the mean age of patients in the study here was 32 years, not 71. So we need to keep in mind the patient populations. In the Ritlecitinib study, the Allegro study, patients had their disease for about 9 years on average. The current episode, the current duration of hair loss was about 3.2 years, and the mean SALT score was 90. And so that's really important. Remember, a SALT of 100 means total hair loss. A SALT of 0 means complete hair growth. So the mean SALT score was 90. So patients in this trial, in the 50 milligram group especially, had severe hair loss. But there were 7 study groups, and I'd like to review this with you because I think this is really important that we reflect on how this trial was designed as we think about the approval that was granted on June 23rd, 2023. So there was 2 parts of the study, the 24-week time point, which was the primary endpoint of this Allegro trial, and then the study continued another 24 weeks. One group had placebo for the first 24 weeks and then received Ritlecitinib 50 milligrams once a day. The second group had placebo for 24 weeks and then received Ritlecitinib 50 milligrams once a day, except the first month they had a high dose of 200 milligrams. And these high doses are being studied in other autoimmune diseases quite readily. Group 3 had Ritlecitinib 10 milligrams throughout the entire 48 weeks. One group had Ritlecitinib 30 milligrams. One group had Ritlecitinib 50 milligrams. One group had Ritlecitinib 30 milligrams, except 1 month of a loading dose of 200 milligrams. And one group had 50 milligrams, except 1 month of 200 milligrams loading dose. So this was the design of the Allegro trial, very different than the Brave AAA trials, where we had either getting 4 milligrams or 2 milligrams or placebo. One of those 3 groups. Here we have 7 groups. So I think this is really important that we reflect on this trial. The primary endpoint was the proportion of patients achieving the SALT score of 20 or less, not at week 36, but at week 24. So that's their endpoint. It's very interesting that these clinical trials' primary endpoints are so different. The data can still be evaluated and looked at and compared, but it is very interesting that one trial has a 24-week endpoint, one has a 36-week endpoint. As more trials come out, we wonder if there will be some standardization or will it be up to the investigators. So if we take a look at the number of patients in these groups, this column on the right side of this graph shows the number of patients in each group. So we have 116 patients receiving 50 milligrams, 112 patients receiving 30 with the loading doses. We have 113 patients receiving 50 milligrams. We have 103 patients receiving 30, 53 receiving 10, and 57 and 60 receiving the placebo initially. How many adolescents were in this trial? Well, about 15%, but there were small numbers in each group, and I think that's important to reflect upon. 20 in group 7, 19, 18, 20, 9, 9, 10. So the largest group had 20 adolescents. How well did patients do? What proportion of patients achieved a SALT of 20 or less at week 24, the primary endpoint? Well, the placebo group had about 2% achieve that SALT less than 20. Placebos are so important, and they're so important in alopecia areata. The BRAVE AAA trials, 6% of patients had a placebo effect in achieving the primary endpoint. 6%. Here we have 2%. But 14% of patients on Ritlecitinib 30 milligrams achieved a SALT score less than 20 or 80% regrowth at week 24. 23% at 50 milligrams, 22% in group 6, and then 31%, just under a third, on this 50 milligram dose with the loading dose. So what dose did the FDA approve? All this data was presented to them. It was 50 milligram dose. It was a 50 milligram dose without any type of loading dose. So the FDA said, we will grant approval to Ritlecitinib 50 milligrams once a day for patients with severe alopecia areata. So they didn't grant approval to 10 milligrams, so let's remove that. They didn't grant approval to 30 milligrams, so let's remove that. They didn't grant approval to 30 and 50 milligrams with any loading doses, so let's remove that. So this is the group that we'll discuss next, because this is the group that reflects the patients that largely we will see in clinic. And the FDA has said that Ritlecitinib in the United States is approved for alopecia areata at 50 milligrams once a day, no loading dose. So what data do we have to look at? Well, we have 113 patients in this group. We have 18 adolescents in this group. And at week 24, 23% achieved the SALT score of less than 20. So how does this data compare? The Baricitinib data versus the Ritlecitinib data? Well, let's take a look together. I think it's really important to think carefully about these trials and how they compare. The Baricitinib trial had individuals 18 and over, but they had a cutoff of 60 in males and 70 in females. The Ritlecitinib data said 12 and up. So the Ritlecitinib data is less, the Ritlecitinib approval and the product monograph, which is coming out, at least the first editions that I've seen, have said it's approved for 12 and over. It doesn't have an upper cap. So the Baricitinib product monograph would say a 71-year-old patient is not approved. That's off-label. If you want to use it, that's off-label. The Ritlecitinib data says 12 and older. They don't go into the upper limit of age. But the inclusion criteria for these trials was a SALT score of 50 or more, so 50% hair loss or more, which we call severe alopecia areata. Patients in both groups had no significant improvement in the last 6 months, and they had to have an episode, their current episode of hair loss lasting between 6 months and 8 years in the Baricitinib group, or 6 months and 10 years in the Ritlecitinib group. There were criteria in the Baricitinib group where it could extend beyond 8 years, but for the most part, 6 months to 8 years that you had been experiencing an episode of alopecia. There were groups that were not allowed into the trial, and they differed slightly between these two groups. And so I think that's really important. We have to think about who's not in these trials. So patients with diffuse alopecia areata were excluded from the BRAVE AA. Patients who had used steroids in the last week or prior JAK inhibitors in the last 2 months, topical JAKs in the last 1 month, were not allowed in the Baricitinib trial. In the Ritlecitinib group, patients with severe depression were not allowed in. Prior JAK inhibitor use, serious zoster, or auditory disease were excluded from the trial. So that's really important, because if you're seeing a patient with severe alopecia areata, with severe depression, they may qualify for the drug. But we have to remember that the Ritlecitinib data did not include that patient group with severe depression. And so we have to think very carefully about who was included and who was excluded. What are the ages? What is the average age? How long have they had the disease? All these are very important to reflect upon. The primary endpoint was the proportion of patients with a SALT score less than 20 at week 36 and a SALT score less than 24 at SALT score less than 20 at week 24 in the Ritlecitinib trial. So the primary endpoint time points were different. The size of the trials was different. Baricitinib was approved for 2 or 4 milligrams, but in patients with severe alopecia areata, like totalis and universalis, the product monograph says start with 4. And so we have about 500 patients in the clinical trial on 4 milligrams. Ritlecitinib was approved at 50 milligrams, no loading dose. There was 113 patients that were in the Allegro trial on 50 milligrams. There was 116 patients on 50 milligrams with a loading dose, but you can see the sizes of these trials are different. There was 117 placebo patients in the Ritlecitinib trial. There was 334 placebo patients in the Baricitinib trial. Both are big trials. 169 centers in the Baricitinib BRAVE AAA trial, 118 centers in the Ritlecitinib trial, 10 countries for the Baricitinib data, 18 countries for the Ritlecitinib data. These are huge studies. Large proportion of patients female, and a large proportion of patients with varied racial background. And that's really important. 60% white in both groups, a third Asian, slightly more patients Black in the Baricitinib trial. Again, really important that we have varied patient backgrounds as we come to understand how these drugs might differ in different groups. The Ritlecitinib trial, the Allegro trial, had slightly younger patient mean age because they included adolescents. So that's not surprising. The Baricitinib trial had no adolescents. The Ritlecitinib group had adolescent patients in each of those 7 groups. They had 18 adolescent patients in the 50 milligram group. That was the dose that was approved by the FDA, 18 adolescents. So that's really important that we reflect on that. There was 19 patients in the 50 milligram group with the 200 milligram loading dose, but a loading dose was not approved by the FDA. So there was just 18 patients in the 50 milligram group. So Ritlecitinib is the first drug approved for 12 to 17-year-olds with severe alopecia areata. And as we think about this data, we have to keep in mind that there's just 18 patients in that group. So not a large proportion of adolescents in the Ritlecitinib 50 milligram group. Patients in both trials had the disease for quite a long time, 9 years in Ritlecitinib group, 12 years in the Baricitinib group. The current episode was 3.2 years in the Ritlecitinib Allegro trial and 4 years in the Baricitinib trial. And the mean SALT score was somewhat similar. So patients in these 2 trials had fairly advanced alopecia areata. A large proportion of patients had totalis and universalis. So what are the results? How good is Baricitinib? How good is Ritlecitinib? Well, let's take a look first at the proportion of patients achieving a SALT score less than 20. What proportion of patients got 80% hair regrowth? Well, at week 24, which was the primary endpoint for the Ritlecitinib study, About 23% of patients treated with 50 milligrams achieved that endpoint. In the Baricitinib Brave AA trials, it was around 29%. Remember, we have to be careful about comparing these outright. They're different trials. Different proportion of patients of various backgrounds, different mean ages, different number of years with alopecia areata, different mean SALT scores. So we have to keep that in mind as we look at this data. At week 36, you can see that the proportion of patients in both trials achieving that SALT score less than 20 or less, was pretty similar. 38% in the Baricitinib trial, 37% in the Ritlecitinib trial. At week 48, so we're approaching 1 year, 43% of patients with Ritlecitinib achieved that primary endpoint, and 39% of patients in the Baricitinib group at week 52. So pretty similar. When you look at these data and you form curves, you can see that the trends are pretty similar between these two drugs. Now, what proportion of patients achieved a SALT score less than 10? A SALT score 10 or less means really fantastic regrowth, 90% regrowth. That's a really tough cutoff. Well, at week 24, 14% of patients in the Ritlecitinib trial achieved that stringent cutoff, 19% in the Baricitinib trial. But at week 36, it rose to 23% with Ritlecitinib and 27% with Baricitinib. And look what happens at week 48. 31% of patients on Ritlecitinib, 50 milligrams, achieved that SALT less than 10, 29% with Baricitinib. So as time goes on, a greater proportion of people are getting regrowth. What about adverse events? Well, adverse events are fairly similar for the most part in these two trials. Serious adverse events occurred in about 2% in each group. The proportion of patients that had to stop the drug and stop the trial because of adverse events was around 2% in each group. Infections, herpes zoster or shingles, occurred in about 2 to 3.4% in the Baricitinib trial, depending on the group. In the Ritlecitinib 50 milligram group, it was less than 2%. Upper respiratory tract infections occurred in around 2% in both groups. Urinary tract infections seeming to be slightly higher in the Baricitinib trial, 2 to 4.7%. There was no urinary tract infections in the 50 milligram Ritlecitinib group, and no opportunistic infections. The Baricitinib data goes out to 2 years. We have a lot more data with Baricitinib, and there's been 5 cancers reported so far: a B-cell lymphoma, chronic lymphocytic leukemia, a melanoma, and in situ melanoma and breast cancer. In the Ritlecitinib trial, we have reports of breast cancer. 2 patients have been reported. 1 patient, it was felt possibly related to the drug. 1 patient thought not to be related to the drug. Again, very challenging in these short-term studies to figure out, is this related or not? But I think this just indicates that long-term studies are going to be really important, and well-designed long-term studies are going to be really important, so that we can counsel patients whether there truly are increased risks of cancers. The current thinking in the JAK inhibitor field for alopecia areata is that maybe issues like thrombosis or blood clots are not as much of a risk as we once thought. Certainly infections are, but perhaps heart disease is not. And the cancer issues is controversial. We rely entirely, as you may be aware, on data from the rheumatoid arthritis field for the last decade. And that data from the rheumatoid arthritis field has suggested that when you compare JAK inhibitors like tofacitinib to TNF inhibitors, it seems that JAK inhibitors increase the risk of cancer. But as investigators go back and look at the data, it comes to be that maybe, just maybe, that's not quite the way to interpret it. And perhaps one can interpret it that TNF inhibitors in those rheumatoid arthritis trials reduced the incidence of cancer, and JAK inhibitors did not increase the risk of cancer. So these are very challenging studies to interpret. And so one of the reasons I'm so grateful for you all joining is it is so important that we understand these trials so that we can go forth and participate in the discussion, not only with patients, but with clinicians in our field and in other fields. The design of these trials is so relevant. The massive rheumatoid arthritis data were in patients 50 and over, many of whom were smokers, who had received methotrexate and tofacitinib. And so is that data really relevant to our alopecia areata patients? So what about cardiac events? Well, Dr. King reported at the 104-week data that there was one report of a major adverse cardiac event, none in the Ritlecitinib group, one DVT, PE thrombosis event with Baricitinib, one PE in the Ritlecitinib, felt not to be related. Headaches occur in both groups, about 10% of patients. Changes in muscle enzymes, CK, CPK, 5% in the Baricitinib trials, 8.9% in the 50 milligram Ritlecitinib group, and acne occurs in about 6% of patients, or what we call JAKne. So acne is not uncommon. What I think is really important for all of us on the webinar tonight is to appreciate the drug interactions which are possible with Ritlecitinib. Baricitinib is metabolized by CYP3A4 largely, this liver enzyme. Many enzymes metabolize Ritlecitinib. The drug is cleared by the kidney in both. There's a fecal clearance and responsible for about 20% of the clearance, but the kidney plays a key role. So patients with kidney disease are going to need different doses. There's very few drug interactions that are significant with Baricitinib, but probenecid can increase Baricitinib concentrations. But with Ritlecitinib, Ritlecitinib is a CYP3A4 inhibitor and a CYP1A2 inhibitor. And the one thing that is challenging as you go through medical training is memorizing or keeping in mind what are the substrates and the inhibitors and the activators of CYP3A4, 2D6, 1A2, you name it. But essentially what this boils down to is that patients on Ritlecitinib may not do so well with the drugs listed in this slide. And so there's quite a few. So there's various CYP3A4 substrates that rely on this liver enzyme to break down. And if you are inhibiting it with Ritlecitinib, you're going to have accumulating concentrations. For example, a patient on the statin, lovastatin, simvastatin, atorvastatin, they're going to increase their statin concentrations potentially and have muscle injury potentially. And so there are other statin drugs that don't rely on CYP3A4. And you can see in the lists here that there are CYP3A4 substrates and CYP1A2 substrates. And so a patient on propranolol for migraine headaches is not going to tolerate Ritlecitinib well. So that may need to be a consideration and perhaps another treatment or another JAK inhibitor used. There are antidepressants that don't work so well with Ritlecitinib. Oral contraceptives are CYP3A4 substrates, but fortunately the Pfizer company has looked at least one oral contraceptive, an phenylestradiol levonorgestrel containing oral contraceptive, and looked at do concentrations of the birth control pill increase with Ritlecitinib? That would be a problem because it might theoretically increase the risk of a blood clot. But what Pfizer showed in their data is it doesn't. So that's great news. So there is, at least within a phenylestradiol levonorgestrel containing oral contraceptives, there's no increase in the oral contraceptive in the blood with Ritlecitinib. by virtue of it being a CYP3A4 inhibitor. And so that's very important because it suggests that patients can be on oral contraceptives, maybe, and that's a challenging issue in and of itself, but that the Ritlecitinib does not increase the risk, increase the dose of estrogen or progestins in the blood. So how does one prescribe Ritlecitinib or Baricitinib? Well, the first thing we do is we review the indications and the alternatives. So as you're thinking about prescribing Ritlecitinib or Baricitinib or any JAK inhibitor, and a patient has one patch of hair loss, small coin-shaped patch of alopecia areata, well, this is not treated best with a JAK inhibitor. This is best treated with steroid injections or topical steroids or minoxidil or other treatments. JAK inhibitors are currently approved for 50% or more hair loss. So we need to review the indications. And what are the alternatives? The alternatives may be other immunosuppressants. The alternatives may be waiting longer. The alternatives may be diphencyprone or squaric acid or anthralin. The alternative may be not treating. The alternative may be, etc., etc. So we really want to review the alternatives with patients. And what are the contraindications? There are many reasons why patients cannot go on JAK inhibitors, and we'll review that in a minute, but I think it's really important to reflect on that there's a whole list of reasons. Patients with prior cancer should not be put on JAK inhibitors, generally speaking. Patients with certain age groups may present a contraindication. Patients with underlying immunosuppressive related diseases may not be good candidates. We want to do a number of blood tests. We want to screen to see if the patient has ever been exposed to tuberculosis before starting. We want to do a blood pressure before starting. If there's any concern about heart disease, we may want to do an EKG. And you may want to consider a chest x-ray as well if you have concerns. Either about lung disease, either prior concerns about TB, tuberculosis, or just lung disease itself or heart disease, and then reviewing vaccination status. Before we start immunosuppressants, it's a great opportunity to review prior vaccines, such as the zoster vaccine, such as the pneumococcal vaccine, and other vaccines. If a patient is going to spend 12 months in Africa and they're going away in 2 months, this is a great time to have perhaps the yellow fever vaccine, because we can't use the yellow fever vaccine in a patient already on Baricitinib or Ritlecitinib. So reviewing vaccination status is really important. So there's lots of reasons. This is a busy slide, but it's a busy slide for a reason. It's to remind you that there's lots of reasons why patients should not be on a JAK inhibitor. So prior cancer, smoking would be a relative contraindication. I would probably not put a patient who's smoking on a JAK inhibitor. Advanced age is certainly a consideration in the Baricitinib trial. The Baricitinib trial had strict cutoffs. The Ritlecitinib trial didn't. And so there will be ongoing debate about age cutoffs. Prior blood clots, family histories of blood clots, cardiovascular disease, infections, pregnancy and breastfeeding. We must not use JAK inhibitors in patients who are pregnant or breastfeeding. That data is being looked at right now. And it certainly could be that in some studies there could be some degree of safety, but that data is not all in yet. And so for now, we must ensure that patients don't become pregnant while on a JAK inhibitor. Patients with renal disease may need different doses, or if there's significant renal disease or kidney disease, they may not be put on it at all. Patients with prior gastrointestinal perforations should not be put on JAK inhibitors. The data is clearest with tofacitinib about the link between GI perforations, but it's still controversial. The Baricitinib trials and the Ritlecitinib data didn't suggest that GI perforations are a phenomenon. But again, there's 1,000 patients in the Baricitinib trial, 718 in the Ritlecitinib trial, not 718,000, not 718 million. And so we have to respect that data. And remember, we need patients to be doing blood tests. We need patients to be following up in clinic. We need patients coming in for periodic skin exams, periodic blood pressure tests. And so if patients are not able to attend, then they may not be a good candidate for a JAK inhibitor. A patient who travels a lot, a patient who is very rarely in your city because of their travel schedule. They come in at certain times of the day or weekend and they leave the next day. They cannot attend an appointment. They may not be a good patient to be on a JAK inhibitor. Of course, all of this needs to be taken on a case-by-case basis. So we need to do TB skin tests or quantiferon to see if they've been exposed to tuberculosis in the past, and if they have, they need to have that treated before starting a JAK inhibitor. We want to screen for prior hepatitis, HIV. A whole lot of blood tests need to be done before starting, including liver enzymes, muscle enzymes, and cholesterol. These JAK inhibitors can increase cholesterol levels, both HDL and LDL. It's still not really clear if there's a difference between these various JAK inhibitors in cholesterol, but certainly increases in cholesterol are possible with all of these JAK inhibitors. Pregnancy tests, of course, before starting in women of childbearing age, and body weight. Some of the JAK inhibitors can increase body weight, and they differ. Ruxolitinib increases body weight more significantly than tofacitinib, for example, and baricitinib not that much. But it's important to have a baseline weight. Again, you want to talk about vaccination. You want to have a blood pressure reading. If there's any concern, EKG and chest x-ray, very low threshold to do an EKG. An EKG is a very helpful baseline test to have on board, and it's wonderfully helpful to refer back to in any issue that arises. And that's really important because not everybody responds to JAK inhibitors. 30% or 40% of patients have very significant results, but 60% don't. And so how are we going to help those other 60% of patients that don't really have very good responses with JAK inhibitors? Well, we're going to think about things like oral minoxidil, perhaps, topical minoxidil. And it's really helpful to have an EKG done in the past if you're going to be thinking about combining JAK inhibitors with oral minoxidil with, other treatments. And patients 40 and over, or really any age, but especially 40 and over, you want to consider doing a skin exam. And after starting, patients need blood tests. So for the first 3 months, I do blood tests every month for a whole host of things. CBC, kidneys, liver, urinalysis, cholesterol, CK. Now, some of these do change a bit. Liver enzymes change a bit. Not much. It's not serious. It's not worrisome. CPK or the muscle enzyme changes a bit. Not much. It's not serious for vast majority of patients. We may want to monitor blood pressure. We may consider repeating an EKG down the road if needed, but it's not mandatory in all patients. But the product monographs are very clear that you want to be thinking about TB as you go along. Even though your quantiferon or your TB skin test was negative, you want to have in the back of your mind any possibility my patient has TB or reactivated TB that wasn't caught by a TB skin test. The product monographs make that very clear that we have to have that in our mind. And then as we go along, blood tests every 3 months or so. The Baricitinib product monograph says every 3 months. Blood pressure every 3 to 6 months. Perhaps ordering creatinine yearly, especially if the blood pressure changes. You can get changes in creatinine with some of these JAK inhibitors. And I think for now, there's no real reason to believe that blood tests should be all that different with baricitinib or tofacitinib or ruxolitinib or ritlecitinib or abrocitinib or upadacitinib. And you want to do periodic skin exams every year or so. These JAK inhibitors increase the risk of skin cancer. That's clear. And you want to be monitoring if there's a small increased risk. And so that's important, and that can be done quite readily. They increase the risk of non-melanoma skin cancer especially. Again, long-term good data in our alopecia patients is really needed to understand the true magnitude of risk if there is a risk of melanoma. It's not clear. And if there is a risk of other cancers, it's not clear. That's really what long-term data is going to be so important for. And we will continue to accumulate that sort of data, and it will require very good trial design and very good evaluation to really get a sense of the magnitude of risk with JAK inhibitors. So what are the future questions? Well, Baricitinib has a year head start on Ritlecitinib. So we have much more data. Dr. King presented the 104-week data. We have 2 years of data. Ritlecitinib was just approved June 23rd. And this little yellow and blue capsule is not yet available, but will be soon. So Baricitinib has a head start. We want to know how Ritlecitinib performs in the long term, just like Baricitinib. What is the 104-week data with Ritlecitinib? What is the 5-year data? Do side effects emerge with longer term? And what about adolescent patients? I think it's really important that we continue to study adolescent patients. I think it's really important to reflect on the trial and the small number of adolescent patients, 18, who were in the 50 milligram SOL group. There were 100 or so adolescents in total, or more, in the trial. But remember, some of those had placebo, some of those had 10 milligrams, some of those had 30 milligrams, some of those had loading doses. What's approved is 50 milligrams once a day of Ritlecitinib, and there were 18 patients in the trial that received 50 milligrams from the start to the end of the 48 weeks. And so we have to remember that, a small number of patients. And so when you're seeing a 12-year-old or a 14-year-old or an 18-year-old, yes, we can make some inferences from the large data set that's here, but we have 18 patients in total that really form that patient group that we can compare easily. And do patients maintain good results? Dr. Senna's reporting at the AAD meeting this year is so important, because what Dr. Senna shared with the world is that at 24 weeks, more and more patients start growing hair. At 36 weeks, more and more patients. At 60 weeks, more and more patients. At 52 weeks, more and more patients. But it doesn't keep going up. You wonder if at 2 years, are more and more patients getting nice results? Well, the answer is no. That 10 to 15% of patients lose their nice results. And so there are going to be many patients that are very pleased with their results at year 1 and contact us because of concern that they're losing hair despite continuing the medication. So I think this is so important for us to be aware of, that with Baricitinib at least, not all patients maintain their good results. So what happens at year 3, 5, 10, 20, 40? If you're 20 years of age, then absolutely you do have to think about 40 years of a JAK inhibitor, 60 years, absolutely. If you have severe alopecia areata, the plan will be for long-term, lifelong use for the most part. Yes, there are a small proportion of patients that can stop or taper, but that's a small proportion of patients. And Dr. Senna and Dr. King shared at the AAD meeting that when you reduce the dose, you get hair loss. So reducing the dose for the vast majority of patients with alopecia areata is not a discussion point. And so this 104-week data is really important. Patients start losing hair even though they're continuing the drug. So what happens? And what happens with Ritlecitinib? Is Ritlecitinib the same? Do patients on Ritlecitinib at year 2 grow more hair? Do they keep growing hair? We don't know. We need those data. And finally, the FDA has this boxed warning for all JAK inhibitors infections, mortality, cancer, cardiovascular events, and thrombosis. And that warning is on baricitinib, and that warning is on the product monograph for Ritlecitinib. And so I think that's really important because Ritlecitinib is introduced as a kinase inhibitor. It's a JAK kinase inhibitor, but it's also this TEC inhibitor, and it inhibits 5 other kinases, but it has this JAK stamp of warning on it, the same as baricitinib. So the conclusion is Ritlecitinib is now FDA approved. We have 2 drugs approved for severe alopecia areata. What makes Ritlecitinib so unique is that it's approved for 12 years of age and over. It was the BRAVE AAA trials that led to the FDA approval of baricitinib. It was the Allegro trials that led to the FDA approval of Ritlecitinib. These baricitinib trials are larger. There's about 500 patients that received 4 milligrams. There was only 104 patients that received 50 milligrams of Ritlecitinib. So these trials are different in size and different slightly in design as well. So we have to keep that in mind. We have 52-week data that's been shared in the Ritlecitinib trial. We have 2-year data that's been shared with baricitinib so far. So baricitinib is further ahead in their data. And so we need to continue to accumulate data just like that. And I think that the baricitinib trials have set some pretty good benchmarks in terms of what is expected for reporting. Adolescents were included in the Ritlecitinib trial, and so it's approved for 12 and over with severe alopecia areata, but there were small numbers of patients only that received 50 milligram doses of Ritlecitinib. And for the most part, it seems that these 2 drugs are pretty similar in efficacy. These 2 trials are very different. So we can't compare perfectly week 24 data. What's better at week 24? What's better at week 48? What's better? The trials are different, so we have to keep that in mind. But for the most part, data seems quite similar between Ritlecitinib and baricitinib. And so if you'd like to learn more, this webinar will be saved and posted to our social media channels. I imagine our YouTube channel, Donovan Medical YouTube. And very recently, Skin Therapy Letter invited me to write a review on JAK inhibitors. And this is free online. I'm very happy that this is free online for your review. The Evolving Story of JAK Inhibitors for Treating Alopecia Areata, a review of current progress and future direction. So it reviews the early days of JAK inhibitor use, ruxolitinib, tofacitinib, of course, baricitinib and Ritlecitinib, as well as the role of topical JAKs. Where do they fit in? What are the JAK inhibitors in clinical studies around the world? What countries are increasingly active in clinical trials of JAK inhibitors? And so it's free online, so do check it out. I think you'll find it quite helpful. But I would like to thank you for joining me for this webinar and for all of the interest in tonight's webinar. I really think this is an incredibly exciting time for patients with alopecia areata. We are seeing these new options. I think what's so important is to be aware of how well these work. These drugs don't help everyone. And they help 30 or 40% of patients with more significant alopecia areata. But there's a large number of patients, 60%, who they don't help all that well. And we have to remember that. And we have to not only be there for our patients with alopecia areata who are responding miraculously to the JAK inhibitors, but we have to be there for our patients who don't. And it's quite frustrating to have such high hope and not respond to a JAK inhibitor. And what options are available to those patients as well. And clearly that's a sign that we are not at the finish line yet for treating alopecia areata, that these current JAK inhibitors bring us quite a bit further, but there's a large proportion of patients that don't respond to these drugs. And so further research is needed to figure out why this is occurring. But I'd like to thank you so much. If there are questions, please enter them into the question and answer box, and I will address them. We have a question that has come in saying, looking at the data for the Allegro trials, the Ritlecitinib trials, do you think that the amount of adolescents included is just barely enough to grant approval? So do I think that there's enough adolescents in this trial? Well, certainly I don't sit on the FDA, and so FDA approval is a sign of baseline reasonable safety. It's up to each clinician to really evaluate what that means. Certainly there are many medications that are not FDA approved that I use off-label, and I feel extremely confident in them. There are many drugs that in the world, outside of hair loss, that are FDA approved that, one might argue, are not effective or not very effective. And so I think that ultimately it comes down to each clinician evaluating how they feel the FDA approval process fits in with their own personal views on safety, affordability, feasibility, and effectiveness. And so it's a wonderful question. Do I think that 18 patients in the 50 milligram Ritlecitinib group is enough? Well, I think that, when I think about the Ritlecitinib data, with my experience with JAK inhibitors of all types, ruxolitinib, tofacitinib, upadacitinib, and understanding how Ritlecitinib works, and the number of adolescents that I've treated over the years, my feeling is that, if this can be approved and paid for by an insurance company for this 15-year-old child, 15-year-old teenager, young adult, meeting with his or her parents, making this tough decision, then it probably is enough. But what I think is so important with this data, and what really keeps me very on alert in this field, is I know that this 15-year-old is going to be on this drug, perhaps other drugs that come next, but is going to be on this drug for a long, long time. And so what I really want to see is 40-year data. We have 1-year data. That's all we have so far, and that's okay. We have to start somewhere. But I do know absolutely that the human body responds differently after 1 year, 10 years, 20 years, and 40 years. And so I am on alert for good data, continued sharing of data, both by trialists and by non-trialists who share real-world data, both, to allow me to think carefully about the use and safety of these medications. That's not only for JAK inhibitors, that's for every single medication. And so that's why these studies are so important. And that's why understanding clinical trial design is so important, so that we can reflect on these studies, not only of JAK inhibitors, but all studies. Is this a good study or not? And if it's not a good study, then, perhaps we just need to ignore it or chuck it out. But that's why I think it's fundamentally so important for us to understand these trials. Thank you for that question. What is the proper duration to assess the effectiveness of a JAK inhibitor before considering an alternative treatment? Thank you for that question. Most patients on JAK inhibitors respond within 6 weeks, 3 months, 4 months. That's most people. That's where they start. It's actually quite rapid. But there are some patients with slightly slower responses. And so I would generally like a patient to be on a JAK inhibitor for 6 months, if possible, because there are some patients which have slightly delayed response. But what is so surprising is that most patients on JAK inhibitors respond quite quickly. And it's different parts of the scalp respond differently, but it can be a matter of 6 weeks before you see some significant results. So it can be quite rapid. Some patients with a beard respond a little bit slower than parts of the scalp. The back of the scalp responds a little slower than the front of the scalp, as with other immunosuppressants. But generally speaking, if we can go 6 months in a patient who's really having a sluggish or slow response. But I think if there's no response after 6 months, you really have to think about, stopping. Of course, we may want to consider that, there's a reason that this is a sluggish response or a slower response. Has the thyroid been tested? Are there other reasons it could possibly exist? But after 6 months, I'd probably stop. What's more challenging is to determine whether we should consider another JAK inhibitor. Whether we should consider another JAK inhibitor. Dr. King's data had taught us all that sometimes if you don't respond to another JAK inhibitor, you can respond to another JAK inhibitor. But that's a tough decision, and many patients who fail a JAK inhibitor will fail the next JAK inhibitor. Ritlecitinib 12 milligram trials were recently halted due to the thrombotic events. Yes. How does this situation relate to the identified side effect of Ritlecitinib and Baricitinib? Does it indicate an increased risk of the entire drug class? So thank you for that question. I think thrombosis has to be on our mind, blood clots, when we're using JAK inhibitors. And I think that this decision to halt the 12 milligram trial because of the blood clots is really a wake-up call that there are some safety issues that require very few patients to have a side effect before that group is terminated, before that study group is removed from the trial or switched to a lower dose. Certainly other disease models like rheumatoid arthritis, et cetera, teach us that these JAK inhibitors come possibly with a risk of thrombosis. I think that what these small studies in alopecia areata and the limited follow-up in alopecia areata and the relatively young patient populations lead us to believe is that these risks are very low. And I think we have to be careful because numbers of patients are really small for the most part, and follow-up is relatively short. And I think we'll know that over time. But as we continue to get data from vitiligo studies, continue to get data from atopic dermatitis studies, continue to get data from alopecia areata studies, I think we'll really have a better sense of the magnitude of risk of thrombosis. But I do think it's very much an issue, and it doesn't seem to be a big issue, so the magnitude of risk seems small. But I think we fully haven't come to terms with how we counsel patients. I don't think as a hair loss community we're completely comfortable with understanding the prescription of JAK inhibitors for women with birth control and what that means. How do we manage thrombosis that occurs in patients on JAK inhibitors? And so I think there are a number of issues around thrombosis that we are not entirely sure about in the year 2023. And so what I truly believe is that we have to keep an open mind, continue to study this, as opposed to say the data is so encouraging. We're not seeing much thrombosis in atopic dermatitis studies. We're not seeing thrombosis in these JAK studies for the most part. I think we're not entirely sure, but I think this Ritlecitinib FDA intervention, where the FDA said we have to stop that patient group, is a really good wake-up call that this is a very relevant issue. And so I just think we need to study it more. Unfortunately, the risk seems low, But if there is a risk of if there is a family history of blood clots, if there is a family history of early heart attacks and early strokes, when you're taking a history, I think we have to think carefully about what that means for the patient and whether this, in fact, is the optimal treatment for them. But we will know more in the years to come. But thank you for that question. So I think that brings us to the end of this webinar. I want to thank everyone for taking the time to join me this evening or whatever time of day it is for you. I really do appreciate the interest in today's webinar. Again, do check out the Skin Therapy letter if you're interested. It's a comprehensive review about these JAK inhibitors, and it certainly is a fascinating field that has evolved, starting first from mouse models, moving to the first human studies, 2015, 2014, to here we are today in 2023, halfway through the year with 2 JAK inhibitors approved for alopecia areata, but many, many more JAK inhibitors on the market, and many, many more JAK inhibitors being studied. And so truly an exciting era. So thank you very much for joining me today. This will be posted online, and I hope it'll serve as a reference for you. And if you do have questions, you can certainly post them online as well, and I'll look forward to seeing them down the road and doing my best to answer them for you. Thanks very much for joining me this evening. Take care.